Bismillah ar-Rahman ar-Rahim. Enuresis. Enuresis is urinary incontinence in a child who is considered adequately mature to have achieved continence. It is the most common urologic condition in children. Enuresis is classified as nocturnal, that is nighttime, representing majority of cases with good prognosis, or diurnal, that is daytime plus nighttime, which is more severe and less favorable prognosis. Daytime dryness is expected in the USA by age 4 years. Nighttime dryness is expected by age of 6 years. Another useful classification of enuresis is primary enuresis, that is incontinence in a child who has never achieved dryness, representing 80% of cases, and secondary enuresis, that is incontinence in a child who has been dry for at least 6 months, representing 20% of cases. The prevalence of enuresis at age 5 years is 7% in males and 3% in females. At age 10 years, it is 3% in males and 2% in females, and at age 18 years, it is 1% in males and extremely rare in females. Evidence suggests different rates of bedwetting by ethnicity and culture. Etiology. Enuresis is a symptom with multiple possible etiologic factors, including developmental differences, organic illnesses, or psychological stresses. Primary enuresis. Causes of primary enuresis include: first, maturational delay. Primary nocturnal enuresis due to maturational delay is by far the most common type of enuresis. It is 3 times more common in boys than in girls, and it is also more common in firstborn child and in low socioeconomic classes. A strong family history is present. The severity of enuresis is variable from one child to another, but daily wetting is common in most cases, and the condition may be exaggerated by parental punishment. On the other hand, understanding, encouragement, and simple reward may be helpful. The prognosis for ultimate recovery is excellent. The second cause of primary enuresis include organic causes. They account for only a small number of cases, but they should be routinely excluded. Mental retardation, sacral anomalies like spina bifida and meningeal, and urologic anomalies like bladder, neck, or urethral anomalies are the main causes. In these cases, enuresis is commonly severe and diurnal. Second type is secondary enuresis. It is mostly nocturnal and caused by either emotional stress or organic causes. Emotional stresses, death of a parent, birth of a new sibling, move to a new house, or marital conflicts are commonly responsible for secondary enuresis. Detailed environmental history is important in every case of secondary enuresis. Organic causes include polyuria and urinary tract infection, which should be routinely excluded in every case of secondary nocturnal enuresis. History of dysuria and weight loss are particularly important to exclude diabetes mellitus. Urine examination should be a routine step. Treatment of enuresis. Treatment of the underlying organic causes of enuresis, including UTIs, diabetes mellitus, sleep disorder, and urologic abnormalities, is essential. Elimination of underlying chronic constipation is often curative. Treatment options include conditioning therapy, pharmacotherapy, and hypnotherapy. Conditioning therapy. The most widely used conditioning therapy for nocturnal enuresis is the enuresis alarm. Enuresis alarm have an initial success rate of 70% with a relapse rate of 10%. The use of an alarm requires commitment from the parent and the child. The alarm has a probe that is placed in the underpant or pajamas in front of the urethra. Children with daytime enuresis and small bladder capacity often are treated with bladder stretching exercises, in which the child is asked to practice holding urination for longer and longer periods. A reward system often is used in conjunction with this practice. Anticholinergics such as oxybutynin 5 mg twice to 3 times a day for children 5 years and older often are used for 2 to 3 months during bladder stretching exercises. Pharmacotherapy for nighttime enuresis include tricyclic antidepressant and desmopressin acetate. Imipramine reduces the frequency of nighttime wetting. The initial dose for children 6 years and older is 25 mg, 1 hour before bedtime. The dose may be increased to 50 mg after 1 week. The maximum dose for children younger than 12 years is 50 mg. It is 75 mg for those 12 years and older. The initial success rate is 50%, with a relapse rate of 30% or more, even after 6 months of treatment. The most important contraindication is risk for overdose associated with fatal cardiac arrhythmias. Desmopressin is also used to treat enuresis and has proved to be safe. It is available in an oral form, which is more acceptable than the nasal spray formulation. The oral medication is started at 0.2 mg per dose, one dose at bedtime, and on subsequent nights is increased to 0.4 mg and then to 0.6 mg if needed. This treatment must be considered symptomatic, not curative, and has a relapse rate of 90% when the medication is discontinued. The last modality of treatment is hypnotherapy. Has a reported 44% success rate without relapse. An additional 31% showed significant improvement in the number of dry nights. Hypnotherapy for enuresis should be offered by health or mental health professionals who are qualified to evaluate and treat enuresis by other modalities and who have training in pediatric hypnotherapy. شكرا جزيلا لإصغائكم.